to start. Good evening, everyone. I welcome you all for this post-Diwali Meet the Expert session of EOC in India. And today we have an interesting talk on immune basis of epilepsy by Dr. Derek Chang. I request our President, Dr. Shefali Goretti ma'am, to introduce the speaker, the moderator for today's and the expert for today's session. Over to you, ma'am.
Thank you, Mahesh. Welcome you back after the 2-week gap. And looking forward to meet you all for the AOCCN 16th to 20th September next year. Today we have an excellent speaker, Dr. Derek Chang, who's going to be talking about immune dysfunction and inflammation in epilepsy. Can I have the CV slides, please? Yeah, the registration as well as the abstracts are open that we will talk later. Yeah. So Dr. Derek Chang is a senior consultant at KK Women's and Children's Hospital, clinical scientist, Singh Health Director, Singh Health Medical Technology Office, Singapore. And he has had lots of achievements. He's got the National Service Excellence Award, Singapore Armed Forces, Singh Health Long Service Award, Singapore Health Quality Service Award, STAR, KK Pulpal Development Awards, and too many more. He's the star of that region, and we all know about him. Thank you so much for joining. He is 2.5 hours ahead, so he's going to be from 10:30 p.m. to 12 midnight for him. We're really grateful that he's joining. And our experts are Professor Dr. Vijay Shudani, who needs no introduction globally. He's an icon in himself, and he's been there as PD Hinduja National Hospital and BJ Wadia Hospital for Children, Mumbai. Very, very well acclaimed professional. Thank you, sir, for joining. Dr. Banu Anwar, we're very grateful that you're joining from Turkey, a professor of pediatric neurology. Education and training has been in Hacettepe University, Ankara, Turkey, and has been trained in neuroimmunology at the University of Chicago, USA, and has an academic career in Hacettepe University till 2023, and now started in a private hospital in Ankara. Neuroimmunology and demyelinating disorders, inflammation in the CNS, and assessment and disturbance of brain development children are her core areas of interest in lots of publications. Thank you, Dr. Banu, for joining. And we have our dear friend, Professor Maya Thomas, who's heading the pediatric neurology in the Department of Neurological Sciences, CMC Vellore. And her interest in pediatric neurology and epilepsy. And thank you, Dr. Maya, for joining. And our moderator is a very dear friend and our alumnus, Colonel Vishal Sondhi, who is currently posted from the army in Srinagar, Jammu and Kashmir. And he was our alumnus, as I mentioned, and his areas of interest are clinical neurology, neuroinflammation, and DRE, and has lots of publication, professional par excellence, and a wonderful, humane individual. Over to you, Vishal.
Thank you, ma'am. I think since Dr. Derek is already way ahead in the time zone, so over to you, Dr. Derek, without wasting any more time. You'll have to unmute yourself.
Yes, suppose. Thanks. Yeah, just sharing my screen. So I just want to say a quick word of thanks. Thank you so much to Shefali and all of my colleagues from India for this kind opportunity to speak. I will proceed without any further ado because yes, time is ticking on. So my talk is on immune dysfunction and inflammation in epilepsy, and these are my disclosures. No relevant conflicts of interest. And so this is the outline of the talk. So why think of inflammation in epilepsy? And we're going to look at Rasmussen's encephalitis, the archetypal immune dysfunction in epilepsy, as well as lessons from newer entities, autoimmune encephalitis, fires, and autoimmune epilepsy, and then look into inflammatory mechanisms in epilepsy and see what the future holds. So the etiologies of epilepsy from the ILAE list is wide-ranging, but immune is one of the well-known etiologies. And if we think about immune dysfunction, it's not a new implication. Infantile epileptic spasm syndrome, which responds to high-dose steroids, we've known this for many years, and we know it's now unlikely to be neurosteroid-related. Refractory epilepsy has often been treated with steroids, probably for the last 60-odd years. But interestingly, we actually lack evidence, and most of what we know in this area is in case control studies, and we really have very little control data. As a result of that, we don't have a strong consensus on the type, or dose, or duration, and the patient selection. And most particularly, we have no real very deep molecular studies into the mechanism to help us understand this better. I'll start talking, of course, with Rasmussen's encephalitis, because this is an archetypal immune-mediated epilepsy. And as you know, this is a chronic inflammatory disease of the brain, and is onset more often in childhood, less in adolescence and adulthood. And it presents with, or manifests with frequent seizures and status epilepticus, and many of them have epilepsia partialis continua. The diagnostic criteria consists of this progressive neurological deficit at the beginning or after the onset of EPC, but before treatment. And they have a progressive hemispheric atrophy on neuroimaging, as well as either evidence from clonal antibody increase in cerebral spinal fluid, or if a biopsy is taken, we see chronic encephalitis. In terms of the clinical course, we can look at the Montreal Neurological Institute classification, and there's that prodromal phase with infrequent seizures, occasionally some hemiparesis, but more commonly we encounter them in our clinical practice when they are mainly in the acute phase. And this is when they have frequent simple palmotor seizures, a majority of them having epilepsia partialis continua, and they develop that hemiparesis and as well as cognitive and other deficits. And on the MRI scan, we see these signal changes and hemispheric atrophy. And then the third stage, the residual stage, is where they have essentially burned out and become permanently hemiparetic, and the seizure frequency falls off, and they have moderate to severe cognitive deficits. On the EEGs, we see that unilateral abnormality, and as the disease progresses, they have bilateral discharges with lateralization. The background's abnormal, and they have interictal focal and multifocal discharges, as well as lateralized or localized seizures. But of course, with EPC, we see poor electroclinical correlation. Interestingly, then, this is where the immune aspect becomes clearer. When we look at the histopathology, this is where we see microglial nodules, phagocytosis of the neurons, cuffing of the vessels with lymphocytes and monocytes, as well as scarring. And here you can see on the left, H&E staining, you can see that lymphocyte and monocyte gathering around the vessels. And on the right side, the Golgi stain, you can also see those accumulation of those immune cells in the perivascular area. So what is the evidence for immunological involvement in Rasmussen's over and above the histopathology? Well, we've talked about the widespread vasculitis, and if we stain these, we can actually find that there are immune antibody as well as complement binding. And in active Rasmussen's, we can actually see membrane attack complexes, so we can see active inflammatory processes going on in these patients. And if we study gene expression in these patients, we find that there's upregulation of the inflammatory genes. Now, interestingly, if we try to figure out which one of these mechanisms is most responsible, there is evidence for both. So we have B cells, which are more antibody-mediated immune reactions, and anti-glutamate receptor antibodies are actually present in Rasmussen's patients, the anti-GLUR3 and the anti-GLUR2 antibodies. And if we inject those antibodies into animal models, they reproduce the same phenotype. And in the patients, we can also see that there's this clonal expansion of B cells. So they are producing larger amounts of these specific antibodies in these patients. And the mechanism postulated is that these directly stimulate the receptor ion channels, and they cause excitotoxicity, or potentially they indirectly do this through complement-mediated cytotoxicity. Interestingly, if you look at T cells, there's also evidence of T cell activation in Rasmussen's. So we see increased cytotoxic T cells in the peripheral blood, and in the cerebral spinal fluid, we see increased interleukin-6. If we treat them, the cytotoxic T cells would fall. And if we look at MHC1 expression, which activates T cells, that is increased in patients with Rasmussen's. We also find those infiltrating lymphocytes like you saw earlier, and the histochemical characteristics are predominantly cytotoxic T cells in some studies. And then you have they mediate astrocyte loss as well in this disease. So interestingly, you have elements of both T cell and B cell mediated immune damage to the brain in Rasmussen's. Now, we all know that the definitive treatment of Rasmussen's is hemispherectomy, and that limited resection is of little benefit. Sometimes the timing is debatable because of this kind of stuttering course of Rasmussen's, and it's often difficult to convince parents and patients to go for such a radical treatment in early stages. Hence, immunotherapy has often come in as a stopgap early in the disease. And if we look at how we aim to use immunotherapy, we can see from this diagram essentially that the goal of immunotherapy is usually typically given in the acute stage. And the goal is really to try to mitigate the damage done in terms of cognition, motor function, by dampening the inflammation, and then therefore reduce the hemispheric atrophy. And there are some nice older studies on kind of therapeutic ladders of what immunotherapy can be used. This one shows use of methylprednisolone, plasma exchange, IVIG, protein immunoabsorption, and cyclophosphamide. And across a various range of patients shows that there's, again, variable outcomes. Some have no response, some are transitory, and some may improve for months or even years at a time. One of the more recent additions to this armamentarium, if you like, is rituximab, and this is an anti-CD20 antibody. So the CD20 antigen sits on the normal and malignant pre-B cells and mature B cells. And so when we administer this, what essentially happens is that we deplete the normal and malignant B cells in vivo. It's typically used in a lot of rheumatological diseases and some paraneoplastic diseases, but has been used in patients with Rasmussen's. There was a pilot study many, many years ago when I was first starting training, and which was registered with clinical trials, but we never really saw the update for that. But I have seen recently in the literature that your colleague from Pune actually published a nice case series of patients with Rasmussen's encephalitis who were not suitable for surgery and therefore were administered rituximab, and showed, again, a variable response, but several cases which showed a good response to rituximab. Hence, immunotherapy does play a role in Rasmussen's encephalitis, but the picture is far from complete. Now, turning to lessons from other immune-mediated brain disorders, if we look at autoimmune encephalitis, of course, we know that now the list gets longer and longer, so I just list the main ones, and the kind of top two is the NMDAR and VGKC mediated encephalitis. And so, of course, NMDAR encephalitis typically presents with neuropsychiatric symptoms, movement disorders, autonomic features, cognitive and memory changes, but significantly, 70% of them have seizures. Sometimes it's difficult to differentiate certain elements from the MRI scan. The CSF can show pleocytosis, or at other times may appear normal. And the defining feature of this essentially is the positive anti-NMDAR antibodies. And these can be if testing is done, can be found to be in the cerebrospinal fluid, as well as the blood. And if stained, we can actually see them binding to the neurons and causing damage thereof. VGKC encephalitis, of course, perhaps the seizures and the status epilepticus is perhaps more prominent, but they also have the cognitive and behavioral changes. Again, MRI brain often normal, so not always useful at the onset, and they can manifest as limbic encephalitis, CSF rarely showing pleocytosis. So the nice thing about autoimmune encephalitis is that it actually has started to give us a handle on some of these patients with this phenotype, which previously was attributed to infection. Here's a very nice kind of paper basically showing a treatment pathway which can be followed, and this is published by Shefali and Manjari and colleagues. And as well, we have also published on some novel antibodies, so glycine receptor antibodies, and been able to show that if you're able to intervene with immunotherapy very relatively early in the course of disease, you can actually cause resolution of the clinical symptoms. And sometimes we will also be able to measure the antibody titers and show that these actually fall. So the significance of this actually is very important and has brought us forward in terms of clinical management, proving that first of all, autoimmune encephalitis is treatable. And also, secondly, that it gives us clearer phenotypes and biomarkers to drive treatment. The immunotherapy ranges from methylprednisolone to IVIG to plasmapheresis and rituximab, and correctly diagnosed early and with persistence in treatment for an adequate length, and in NMDAR, this may extend to 1 to 2 years, we're actually able to return a relatively normal, almost completely normal patient. Now, another entity which has gone through several iterations is actually FIRES. This has had many different acronyms in the past, but now currently we call it febrile illness or infection-related epilepsy syndrome. And this presents in the acute phase with normal child with a transient febrile illness who then has recurrent focal seizures, sometimes a stuttering course over several weeks, and then gradually evolving to refractory status epilepticus without any specific neurological features. And they can have subclinical and very subtle seizures, and the duration of the disease illness can be weeks to months. If we do investigations, oftentimes we'll find that the lumbar puncture is normal or maybe a transient pleocytosis. Neuroimaging initially can be normal, and sometimes we see some flare or T2 changes. Infection screening and metabolic screening is typically negative, or perhaps just a simple virus, which may be a trigger organism, but not neuropathic. And EEG monitoring can show subtle or subclinical seizures, which are commonly multifocal. And this is a typical patient with FIRES who just their EEG is kind of sits at that ictal interictal continuum with continuous bursts of high amplitude spikes and waves, at times seizing, at times not clinically seizing, but clearly in bad shape. And the outcome for these patients in the past, and probably it's falling, used to be high, close to 70%. It ranges from 11 to 70%. And once they have come through that acute phase, they have commonly had drug-resistant epilepsy, neuropsychological impairments, and of course, this entire disease has significant psychosocial impact on the entire family unit. In terms of treatments, we have always used anti-seizure medications, our standard anti-status epilepticus protocols at our respective centers, and then with refractory status epilepticus, gone through the ladder of various treatments such as midazolam, thiopentone, supramaximal phenobarbital. Some will use intravenous valproate, levetiracetam, as well as topiramate. When it gets more severe, we move towards halothane anesthesia, lignocaine, although we tend not to use propofol because of the problems with that in children. Magnesium sulfate has been used, and as well as we have more latterly ketogenic diet, immunomodulation, vagus nerve stimulators, therapeutic hypothermia, and most recently anakinra and tocilizumab. And the ketogenic diet and anakinra really have become more and more the mainstay of treatment. In the past, FIRES, the immune basis of FIRES was really questioned. It was felt perhaps not to be, but I think that thinking has really shifted. And now anakinra is, for at least our center, we will administer it within a week or two as fast as possible once we are sure of the diagnosis of FIRES. Turning now to autoimmune epilepsy, so this is something which is becoming more well known, and this essentially is epilepsy with anti-neuronal antibodies. I'm not going to go through the list in detail, but you can see from this there's many antibodies which are associated with these, and they're anti-neuronal. And the features of them are frequent or severe seizures with at least one anti-neuronal antibody proven on testing, as well as inflammatory changes in the peripheral blood and the cerebral spinal fluid or MRI brain. And sometimes you'll find there's also a personal or family history of autoimmune disease. Now, how do these autoantibodies cause disease? They cause it most likely through imbalance through excitatory and inhibitory drive. And these antigen targets of these antibodies are neurotransmitter receptors, ion channels, key enzymes, or their membrane proteins, and these cause conformational changes or ligand-induced changes. They alter the voltage-mediated gating and essentially alter polarization on the membrane, and through a variety of effects essentially cause hyperexcitability. I won't go through this in detail, of course, but basically this just is a diagram to show the types of autoimmune antibodies which are found in patients with autoimmune epilepsy and which, as I said, can impair the balance between neurotransmitter, excitatory, and inhibitory systems, and in so doing produce epilepsy. And if we look a little bit deeper at the various immune factors, not only antibodies are involved, but the HLA system, as well as T cells, cytokines, are all involved in this and basically contribute to damaging the healthy brain and leading to autoimmune epilepsy. And of course, it was very nice as I was updating this talk. It was very nice to see this paper by Shefali and team, again, looking at immune-mediated epilepsy, so becoming more and more prominent in our minds. This can be a little bit confusing though sometimes because we have autoimmune encephalitis, we have autoimmune epilepsy, and we have neuroinflammation. So we can differentiate some of these on clinical phenotype and severity. The immunological characteristics, at least for the anti-neuronal antibody-driven, is relatively clearer, but perhaps we don't understand quite as much in those which have very immunity-driven etiology. So we need to have some kind of handle to help us choose and calibrate treatment accordingly. And I'm not going to say that I have all the answers here, but we're just going to talk a little bit more about these. Now, this is a very nice slide, which I've kind of borrowed from Professor Christian Bean, which we did in our session at the IEC in Dublin some time back. And essentially, it is possible to order these conditions based on the phenotype and their response to treatment. So you have the autoimmune encephalitis and you have your autoimmune epilepsy, which are more the result of an adaptive immunity abnormality. And you can see, like the phenotypes, I won't go through those again. And then you have those which are perhaps due more to innate immunity. And this constitutes things like perhaps fires. And this is questionable, but actually a very compelling question, potentially all the pharmacoresistant epilepsies, which may then be driven by more of an innate mechanism. We actually had a very we were actually very curious what the differences or similarities were between refractory epilepsy and autoimmune encephalitis. So we actually performed a study looking at the peripheral blood of patients who have either a new onset autoimmune encephalitis or a kind of a established refractory epilepsy. And quite interestingly, when we look at the blood profiles, we can see that compared to clinical controls, these patients actually share certain common characteristics. Both of them showed upregulation of immune dysfunction, but they were also slightly distinct. So we were able to show that there's actually some upregulation of the Th17 pathways in refractory epilepsy. And Th17, or the T helper 17 cells, are associated with induction and tissue destruction in autoimmune diseases, as well as T cell lineage maintenance. Now, other features which suggest that inflammation is implicated in epilepsy, we've already talked about GLUR3. Some kids with autoimmune encephalitis are seronegative, but we see also people with systemic autoimmune conditions and pre-existing brain inflammation conditions having that increased disposition to seizures. All right, and in animal models and some humans, we can see pro-inflammatory molecules and receptors are upregulated. Neuroinflammation, so when we talk about neuroinflammation, I'm kind of referring to antibody-independent inflammation, kind of more innate. And so this is an innate immunological response of the nervous system involving its own immune cells. So these are the microglia and the astrocytes, and they release cytokines and chemokines and cut loose the inflammatory cascade, essentially leading to basically cascades of inflammation in the brain itself. And this is not solely associated with epilepsy, but it happens in many diseases. So neurodegenerative diseases, brain injury, stroke, aneurysms, glioma, because we must remember that inflammation is essentially a disordered repair mechanism of the body. If we look at some of the neuroinflammatory molecules implicated in epilepsy, we have those which are very fundamental, so interleukin-1, interleukin-6, TNF-alpha, and as well as the chemokines. And these act not only at the neurons, but also at the blood-brain barrier and through a variety of cells, such as the macrophages and astrocytes. And perhaps more relevant for us as child neurologists is actually the fact that there's some evidence that with the developing brain, we actually have different reactions to inflammation compared to adults. So we have rat models which show that neuroinflammatory responses to seizures in the developing brain are slower, weaker, and less persistent. They can be prevented by some drugs which block microglia and astrocyte activation. So there's already some evidence that maybe neuroinflammatory response in humans could be age dependent. But that's not necessarily a good thing, because although they're milder and slower, actually it's possible that the immature brain might be permanently modified by just that transient inflammatory episode, or they could go through what we call immune priming, which essentially means that they are predisposed to an extreme immune response to a second hit, which is very tempting to attribute something like fires to. And this inflammatory mechanism then, through post-translational and transcriptional changes to ion channels and neurotransmission and synaptic plasticity and astrocyte homeostasis, basically causes that process of epileptogenesis. Here you have a really nice diagram of how this could be happening. So on the left, you see this early inflammatory hit to the brain, and then you have neuroinflammation, and then it begins this cycle essentially of activating the interleukin-1s and the toll-like receptor signaling, and then causing essentially increased excitability, seizures, which then beget cytokine cascades and chemokines cascades, which stimulate more inflammation, and then over a period of time, essentially drive the brain towards more seizure activity, worsening cognition, and essentially towards pharmacoresistance. So this is one of the theories behind the development of refractory epilepsy, is this early inflammatory hit and then this ongoing neuroinflammatory cascade. So we've got these multiple mechanisms implicated in epileptogenesis. And if we look at it, there are various areas in the brain that these can be taking place. And this ranges from the blood-brain barrier to cellular infiltration into the brain, as well as intrinsic microglial activation and then reactive astrogliosis. The blood-brain barrier, we sometimes call it the neurovascular unit in epilepsy. So essentially, we all know it's the physical transport and metabolic barrier between the brain and the blood. And it comprises these endothelial cells with tight junctions, basal laminar matrix, pericytes, smooth muscle cells. And for the longest time, this has been felt to be an impermeable barrier, and give us the kind of immune privileged nature of the brain. But that's actually not really true. And even if we take that to be true, the blood-brain barrier can be disrupted in all sorts of situations, infections, trauma, etc., which leads to that edema, inflammation, hyperexcitability. And this is, again, just a quick example. It shows how that blood-brain barrier can be attacked by all of these inflammatory processes breaking down and then allowing that selective membrane to be disrupted. And in so doing, leading to hyperexcitability and seizures. So when I started my work, it was actually extremely difficult to be funded, because the paradigm of the immune privileged brain was one which was set in the kind of group consciousness and actually very hard to break down. But as time has gone on, we actually realized that this is indeed not true. And actually, the brain is very, very intimately involved with the peripheral immune system. First of all, we have now got proof of brain lymphatics, and these actually permeate the brain and actually bring the lymphatic system of the peripheral immune system in close opposition to brain tissue. And we also see through mouse models that monocytes actually from the peripheral blood actually can migrate to the meninges and can actually infiltrate the brain parenchyma and differentiate into macrophages. So there is actually this close relationship between the peripheral immune system and the immune milieu in the brain itself. I'm just going to pause, just kind of like take an example here for just to a clinical case, just to give you an example of sometimes how confusing it could be. So explosive onset epilepsy, I think commonly we see these, and sometimes they're assumed to be immune. This is a patient of ours who had early onset seizures, 2 years old, rapidly worsening, treated with steroids at another center for autoimmune epilepsy, and then came to us and was referred to our epilepsy team, and was having frequent seizures, many seizures a day. And essentially, the scan previously had been reported as normal. But interestingly, when we look at the EEG and took a really close look, actually we could identify that this one actually was a basosulcus lesion, quite a large basosulcus lesion. Went through the operation, did ECOG, did depth electrodes, and actually could resect the tissue. So the phenotypes, sometimes we can pull the trigger too quickly and think of autoimmune epilepsy or autoimmune encephalitis, when actually it is our good old friends, the cortical malformations or basosulcus lesions, which are just manifesting with an explosive onset. But it did give us an interesting question, which we thought we could try to answer, was can we find ways to treat refractory epilepsy like this less invasively? Because it's a very traumatic situation for the family to go through, and it's quite stressful for us as well. So one of the aspects or approaches that we've adopted is high dimensional analysis, because traditional hypothesis testing and the methodological limitations focused on specific interactions within the immune system. And so oftentimes you would focus in on relatively few bioinflammatory markers. And of course, if you only test certain things, then what you see is what you get, basically, which constricts our view of immune interactions. So high dimensional analysis actually enables us to have a wider observation of the complex immunological systems that are interacting within the brain and in the blood. And this is a paper that we did. So taking advantage of the fact that we had these patients who needed to have their surgery, we actually analyzed them with single-cell transcriptomics and actually were able to detect that indeed we do find inflammation in the brain of these children. And particularly that actually we find that it is microglia and the infiltrating immune cells actually show inflammatory signaling, which are more along the lines of innate immune dysfunction and resemble actually multiple sclerosis. If we look at the cellular staining, that we actually find that there's co-location of the microglia as well as the macrophages and the T cells along these neurons and astrocytes. And we find that we can identify interleukin-1b closely as binding to these areas. And essentially that proves that we have this inflammatory pattern going on. We further went on to actually look at the ligand receptor analysis. So this is actually looking at the cell markers, and basically we're able to show that the infiltrating immune cells are closely associated with the neurovascular unit or the blood-brain barrier. So essentially, our translational work is starting to show that refractory epilepsy actually straddles innate and acquired immunity. They do share some common features, but as we said before, there appears to be this Th17 pathway, which is upregulated in childhood refractory epilepsy. And this is perhaps starts to be a handle on how to tackle refractory epilepsy from autoimmune encephalitis, but by no means do we have all the answers yet. There are actually still many pharmacological targets and candidate treatments in neuroinflammation. And many of these have been tried in the past, and they target various things such as interleukin-1b, they may TGF beta or NK-kappa B, NF-kappa B, or toll-like receptor 4. So there are many of these things which target various immune pathways within the brain. And we have to remember now, we talked about anakinra being used in fires. So virus is such a severe disease that actually we have to hit it really, really hard and really, really fast. But we must remember, of course, that a lot of our patients aren't actually that severe or obvious, and sometimes they can have quite a stuttering or subacute course towards their refractory epilepsy. So we have to now think about how to balance that clinical course against the strength of the immune treatments that we could potentially use. And it's not really clinically sound to probably give anakinra to every single child that we think might progress to refractory epilepsy. If we look at inflammation, the other thing we have to think about is, do we really want to completely suppress inflammation? Because this, of course, comes with, first of all, the risk of chronic immunosuppression, but it also will interfere with the positive healing effects of inflammation, because inflammation is there for a purpose. Rather, what we need to figure out is how to modulate that inflammation to reduce it at its highest, permit appropriate healing without allowing it to cause scarring and damage. I just shared this really interesting example of in the animal world. So the spiny mouse is the paradigm of scarless healing, right? A lot of our damage that we see in the central nervous system is not due to the damage itself per se, but sometimes related to the scarring and damage that occurs as a result of that during the healing process. And the spiny mouse is a very interesting animal in that it is able to have a significant damage, like it can have half its skin torn off, and it will heal completely without scarring. And because of this, researchers have actually gone to the lengths of actually causing transection of the cord in these mice. And they have been able to show that because of the lack of scarring during the healing process, these spiny mice are actually able to reform the connections and actually regrow their connections down the spinal cord, reconnect, and actually regain neurological function. So this is perhaps something to aspire to in terms of how we hope that our future treatments will benefit our patients. So take-home message is our understanding of immune involvement in epilepsy. You know, it originated with Rasmussen's encephalitis, and then autoimmune epilepsy has brought the focus on anti-neuronal antibodies. But immunity plays a fundamental role in epileptogenesis, not only of acquired immunity, but also involving the innate immune system. Like we shared, the high dimensional analysis really holds great potential to unlock the complexities of these inflammatory interactions. And it's starting to show us potential targets and lines of therapy for epilepsy, but we still need to elucidate the links from the peripheral to the immune system dysfunction, because it's not directly mirrored. And we also have to be cautious in our approach to therapeutics for inflammation in epilepsy, and really not to give too much nor too little, so as to be able to modulate that healthy inflammation without pathological healing. With that, I will end my talk there and just say thank you very much for the opportunity to speak. Thank you.
Thank you, Dr. Derek. It was fabulous, and to cover it within 40 minutes, you gave a fabulous overview. We will have a quick comment by our experts, and I'll request Dr. Udani, sir. We will start with you. Your thoughts.
I mean, thank you very much, Dr. Chen. I was really, the last part of your talk was extremely illuminating. And I was, in fact, thinking of what we see in our set of the maximum patients of epilepsy we have, drug-resistant epilepsy, are patients with perinatal brain injury. And one wonders whether, the inflammation which follows the brain injury may be actually partly responsible for the epileptogenesis which develops into this drug refractory epilepsy, and whether any strategies can be used to at least modulate this inflammation, as you so well put it. I mean, what are your thoughts on that kind of thing?
Yeah, I think, Professor Udani, it's wonderful to meet you properly, because I think we've had joint patients, so it's lovely to be able to speak to you. A great honor. Yeah, I completely agree. I think that it is very important that we figure out how to modulate it. a lot of our treatments have been perhaps quite empirical, right? I mean, steroids, a lot of people use steroids empirically for refractory epilepsy. And the difficulty, I think, is we don't have enough of a handle on exactly what's going on in our patients, right? So the clinical phenotype, although it's improved, it's still not telling us enough information for us to be able to refine our treatments, so delicately. So I think that molecular, the kind of high dimensionality analysis is something that we all together need to, be gathering these samples and phenotyping our patients so that we can put this all together and go, okay, figure out which of these biomarkers means what in this group of patients. And I think from there, we will start to be able to tune our treatments.
Yeah. Just one more question. Do I have time, Vishal, or just?
No, sure, sir. All
I
yours.
to ask about the fires, and do you talked about anakinra, and people have talked about tocilizumab and all that. Do you, in your practice, do you all do interleukin, case of interleukin studies, early fires to actually target treatment? Depending on what the cytokine panel is showing, do you sort of according to that, monoclonal?
Yeah, I guess so. We all know that these kind of interleukin studies and they all take time, right? So we actually recruit them to our research program. So the kind of transcriptomics you do, we actually recruit them to our research program. But that's going to be something that's going to give us results much later, and it's usually pooled data. So at least in my practice, I still go very much by the clinical features, right? The clinical course, the evolution. When it becomes clear that they're heading in the direction where clinically they fulfill the criteria for FIRES, yes, then I will actually use anakinra, which is a very powerful drug, and it's very broad spectrum. It shuts down your immune system essentially because it targets very high up in the immune pathway. But we have started to see very good results when we do that very early in several of our patients, as in the recovery of function. Thanks for the questions.
Thank you. Dr. Banu, your thoughts, please.
Yes, hi. May I first? I'd like to summarize what I think of the neuroinflammation versus the antibody or specific cell response. The neuroinflammation is a reaction that is intrinsic to the nervous system. That means glial cells, astrocytes, and microglia. They are reacting and forming the neuroinflammatory milieu, whilst the specific responses, either cellular or B cell or T cell responses, come generally from the periphery, because we know that lymphocytes normally, maybe a few latent lymphocytes exist in the central nervous system. Now, the innate immunity is the effective branch of the immune system in FIRES in these acute epilepsies. On the other hand, like in Rasmussen's and several others, and antibody-mediated one, it is the adaptive immunity. In general, in the body, we know that innate immunity comes first and adaptive is the second. But can we tell, or would it be correct to imagine that in an antibody mediated epilepsy, for instance, NMDAR receptor antibody causing epilepsy, it's the adaptive immunity taken place in the periphery, maybe, and then reacting in the central nervous system, and then the neuroinflammatory part. That means the innate immunity takes place as a secondary. So it's like it is vice versa time-wise.
Yeah, that's a very interesting question. I think we lack enough data sometimes to be sure. That's the big problem. Is I think we have reached the stage where for those anti-neuronal antibody-mediated diseases, we are quite sure about certain biomarkers. So some of the antibodies, I think increasingly in the literature we see that more and more antibodies are identified. But then the question starts to become whether they are actually just a result of the inflammatory process, right? So that's starting to get confusing because you say, oh, this inflammatory process, and then they start to produce antibodies. And then actually, was it that antibody causing this, or is it just the result of the inflammation? So that chicken and egg problem is still there. What I think is we haven't done, which we need to do more, is together create those longitudinal cohorts of patients and actually systematically be measuring these biomarkers, right? And that will give us some idea of what's the temporal relationship, antibodies versus central. Now, of course, the work that we've been doing on a single-cell transcriptomics is not something you can serially sample because those are the patients who've had a brain resection. So what we are trying to do is try to link, basically figure out the mechanistic link between the central nervous system inflammation and the peripheral blood signatures, so that then we can make sense of the peripheral blood longitudinal signals that we're seeing. But this is by no means answered. You're quite right.
That's one way of investigating, but probably there are several ones.
Yes. I mean, this is an approach. Yes. More than happy to hear your ideas on it.
Great, thank you.
Thanks. Dr. Maya, can we have comments from you, please?
Thank you very much, Dr. Derek, for that wonderful talk. And as you very clearly mentioned, immunology in epilepsy is, it's not new. With the ACTH use, and again, steroid use in conditions like Landau-Kleffner syndrome. Also, we use steroids, and also in all these drug-resistant epilepsy, we use steroids. So obviously, immunology in epilepsy is it's something which is long known. But I would say that when we have immune-mediated epilepsies, autoimmune epilepsies, other than autoimmune encephalitis, especially in cases of seronegative cases, that's where the challenge is. So usually we have some criteria to go by. For example, do we follow any of those criteria? So, like for example, that antibodies in epilepsy, that do you follow any of those criteria for immune-mediated epilepsies? Like for example, an electroclinical syndrome which doesn't fit into the usual kind of electroclinical syndromes, sudden abrupt onset of seizures, multifocal polymorphic seizures, drug resistance, and responsive to immunotherapy. Meaning this is what we usually follow. Meaning that's when we say, meaning you look for MRI markers, you look for CSF markers for inflammation, and then you say probably this is an immune-mediated epilepsy. When it doesn't fit into a regular electroclinical syndrome, and we've ruled out all other possible causes. I think, like you already mentioned, these are still evolving, and I'm sure with more and more antibodies being identified, I'm sure things there'll be much more clarity in subsequent years.
Yes, I completely agree, and I think we have a question in the chat about like a patient. So actually, one of the questions was like, explosive onset, focal epilepsy, lesion negative, antibody negative. Is it immune mediated? Things like that. I'm old school. I trained at SickKids, so I go first of all to the clinical phenotype, semiology, MRI. I look at the EEG. And of course, if it's a very focal epilepsy, then we stay very, very suspicious that this is kind of one of our conventional epilepsies, but with an explosive onset. And I certainly had patients who I've shown MRI scans to everybody under the sun, and they said lesion negative. But eventually, we went to hemispherectomy, and sure enough, under histopathology, we find there are abnormal, it's basically cortical dysplasia, a very extensive cortical dysplasia. So I think what our approach in our center is, because over the years we've set up our research program, is we try to do these sampling of these patients before we initiate anything, because once we've started throwing immunotherapy at them, we've lost the signal, right? We cannot see what's going on beyond that. So that's something that I've kind of set up in my own center to begin to try to understand and basically sample them before and after every treatment, immune treatment, etc. And that is something which is a work in progress. So I won't say that we found all the answers, but we hope that by doing this in a very systematic fashion, longitudinally, that we will actually begin to see this become more and more clear. And even for the patients who do turn out not to be immune mediated, I think, like we were discussing earlier, it would be a very interesting to see what are the changes that occur in the course of this patient, right? If we're just using conventional anti-seizure meds, it'll be very interesting to see what their immune system does during that whole process. So yes, the clinical phenotype to some extent helps us. I think, I mentioned Professor Christian Bean. He's got a very strong advocacy for, the therapy is what matters. And if we target them based on the clinical phenotype and we give that therapy according in line to, whether it's autoimmune epilepsy or neuroinflammation or autoimmune encephalitis, that will be almost like be a therapeutic razor, right? It'll help us differentiate.
Thank you, Dr. Chan. We have loads of questions in the chat box, and we have 4 cases lined up. I think we'll start with the cases because a lot of questions might get answered in the clinical discussions. And we'll start with Dr. Hassan. Dr. Hassan and your team, I think you can take on with the first case presentation.
Yeah, thank you very much. Thank you very much, Dr. Chan, for your fantastic presentation. Before our case presentation, do you have an expectation about, in the near future, about epigenetic therapies on the neuroimmune disorders?
Well,
I mean, in micro RNA-based therapies in the future. Today, we use anti-inflammatory medication modalities. In the near future, I mean, in question.
Yeah, no, I get what you mean. I guess the microRNA therapeutics are, obviously more developed and the targets are clearer in those which have a genetic etiology. I think the tricky question is, even if we have clear, and we do have some gene targets which do appear to be associated with inflammation, because the immune network is so complicated. The question is whether or not targeting the gene is actually going to fix that problem.
Yeah, thank you very much.
So yes, so I think that is probably not in the near future.
Oh, thank you very much. Now it's the time. I would like to invite my colleague, Dr. Tuğçe İnce from Ege University Hospital. She's going to present our cases. The case is diagnostic and therapeutic challenges in 2 cases with Norsen virus. Tuğçe, platform is ready for you. Thank you very much. I cut 1 minute from your presentation for my question. You have just only 6 minutes. Thank you.
Thank you. Dear professors and dear colleagues, it's an honor for me to be here tonight. And tonight I will present you the diagnostic and the therapeutic challenges in 2 cases with Norsen and virus. I would like to draw your attention to the age of our cases, and they were completely healthy preschool and school age children before. Case 1 admitted to hospital with confusional state. His fever has started 5 days ago. During the follow-up, he had motor onset seizures evolving from focal to bilateral that progressed to status epilepticus, and he was referred to our tertiary center. And case 2 was 4 years old and admitted to the hospital with focal motor onset seizures with impaired awareness. He had had prior fever for 3 days, and his seizures progressed to status epilepticus, and he was referred to our center too. And from now on, I will present our cases in comparison. And in both cases, fever was accompanying to the seizures, and their status epilepticus both had continued for more than 24 hours, despite the anesthetic agent infusions. So evolved to super-refractory status epilepticus. Due to the fever histories, the primary possible etiology that came to mind was infections, and in case 2, COVID-19 was, which was very current at that time, was also included in our differential diagnosis. We conducted the lumbar punctures of the patients, but there was no significant findings in their CSF samples. No microbial identification could have been done for them. And in their brain MRIs, case 1 has normal imaging findings, whereas in case 2, there were T2 hyperintense areas in left occipital and also diffusion restricted areas in the same region. And our neuroradiologist thought that it could be a COVID-19 related encephalitis. And in the EEG findings of case 1, we observed the presence of sharp waves dominant in the right occipital region, and epileptic discharges were consistent with the seizure semiology of the patient. And 2 electroclinical seizures were recorded originating from the right occipital region and exhibiting intra and interhemispheric spread. And in EEG of case 2, electrographic seizures were detected with the discharges in a rhythmic, semi-rhythmic morphology and originating from the right and left occipital regions with a frequency of 1 to 3 Hertz. And during this period, no motor activity was observed in the patient. It lasted for approximately 130 seconds and recurring in a similar manner during the recording. And we considered it compatible with non-convulsive status epilepticus. And our preliminary diagnoses were FIRES for both cases as a subgroup of new onset status epilepticus. And the possible etiology should be infectious, immune, metabolic, toxic, genetic, or unknown etiology. And we went on our etiological assessments with extended immunological, rheumatological, metabolic panels, and there was no intoxication history in the patient's story and no genetic clues for genetic disorders. At this stage, we clarified the etiological aspects of our patient's diagnosis by evaluating them with their clinical stories. We thought of infectious etiology for both of the cases. We couldn't identify the agent in case 1, but it was considered to be the COVID-19 related disease in case 2. As you can see, we have managed therapeutic challenges in the acute phase under 5 main headings: anti-seizure medication management, the goal of keeping the coma induction period short. As we know, it has impact on the prognosis, and immunomodulatory treatments used to suppress the neuroinflammation in early period, and introducing the ketogenic diet and cannabinoid treatments, which are known to be anti-epileptogenic and anti-inflammatory, as early as possible. And in the post-acute phase, you can see our management under 4 headings. Anti-seizure medications could have been reduced. Ketogenic diet has been continued in both patients for a long time. And in each patient, we use interleukin-1 receptor antagonist anakinra treatment as one of the anti-stalking treatments, as Professor Chen mentioned in his presentation. And anakinra, I have to say something about anakinra, that anakinra is a recombinant interleukin-1 receptor antagonist, which competitively blocks interleukin-1 beta activity. And interleukin-1 beta is a master of cytokine that is suggested to be associated with epileptic pathogenesis by activating the cascade of inflammatory molecules and resulting with brain inflammation. And anakinra is shown to be effective for both acute and chronic phases of the disease. The consensus report states that in severe and recurrent post-acute epilepsy, interleukin-1 or interleukin-6 blockade, like using tocilizumab or anakinra, may have a disease-modifying role. And one of the most important experiences we would like to share with you in this presentation is anakinra treatment that we had given to our patients. And about the prognosis of our patients, we assessed our cases with seizure profiles and functional independence scores. In the first case, anakinra treatment was initiated at the 47th month, and initial functional independence score was 22 for the patient, and the maximum score could be 126. And on the 6th month of the treatment, his score was 58, and at the end of the 1 year, his FIM score was 66. Initially, he was using a wheelchair, and after 1 year, he was walking independently, began to speak with a few words, play games with his mother and his family, and show some effort to communicate, and had better seizure control. And for the second case, he began to get anakinra treatment in the 3rd month of the fires, and seizures were partially controlled after anakinra. We tried to withdraw on the 10th month, but after more frequent seizures, we reinitiated anakinra treatment in this patient. And now you will see the videos of the patient in 18th month and in 24th month. In the first video, while he was using a medical assistive device to walk, in the 24th month, he could stand independently. And as you can see, his fine and gross motor skills were developing. And to take home message, I should say that in NORSEM fires, diagnosis should be made as early as possible to initiate the targeted immunotherapy as soon as possible. And in short and long-term follow-ups, immune modifiers like anakinra or tocilizumab may be chosen by a case-based approach. Thank you for your attention.
Thank you, Dr. Hassan and team. Wonderful case presentation. Any comments, Dr. Chan?
Oh, no, it's just a lovely presentation. I particularly like your brain animation. It's very, very exciting. So very interesting. Well, you know, when I was trying to decide how long to treat my patients with fires with anakinra, I realized there's actually very little literature out there. Most of the literature, I'm sure you find, right? There's almost nothing on how long to treat them for.
Yeah, we have found some long-term usage of anakinra in fires cases, but they also use it in adult patients, and we wanted to try that treatment in our patient in our first case. And I think he first admitted to the hospital 6 years ago, and when we began to talk about anakinra and immune modifier therapies in child neurology, we catched our patient and wanted to try this anakinra therapy for long term.
Yeah, but it's very interesting that you said that one patient, 3rd to the 10th month you treated, and when you stopped, he got worse. So that speaks to almost like a chronic inflammatory mechanism that's persisting, which is very interesting.
Dr. Chen, last month we accepted the second one cases, and then we decided to stop the anakinra treatment after the 3 years later. Then we stopped, we reduced the dosage, and then we stopped the medication. Then the seizures stop again, and seizures start again, and then convulsive status we see. Then we decided to start anakinra and increase the dosage. every 2 years we evaluated the immune system with flow cytometric analysis. We don't have an exactly protocol, so we have to decide how long we continue the medication. I agree with you. Thank you very much for your comment.
But Dr. Hassan, did we do IL-1 levels at any point of time because it was a long duration that we gave, or did we check it at any point of time for any objective evidence to guide our therapy decisions?
Yeah, there is no guidance. Also, we hesitated to continue the medication. Then we consulted with immunology department. They suggested that why don't you check the TB cells and the TB cell functions, and then we decided there is no clear algorithms.
Yeah, because this is a complete paradigm change in the management
Yeah.
of works. Yep.
Okay, thank you.
Dr. Maya, any comments on this?
No, I particularly don't have any experience with anakinra, but did you try any other immunomodulation like IVIG, monthly IVIG, because that is the usual standard of care, meaning IV methylprednisolone, IVIG, and then if there is no response, then you go on to use rituximab or tocilizumab. Did you use any of those immunomodulatory treatment prior to anakinra, and you didn't find a response and then you switched, or what was your protocol?
Yes, we have used both of the therapies, steroid therapies and also IVIG therapies monthly, and but still our patients had refractory seizures, so we decided to try anakinra.
Okay.
And also, it depends on the diagnosis of the primary diagnosis. We have a lot of patients with Rasmussen encephalitis. We started the IVIG therapy. If your question about specifically on the virus or Norsec cases, we didn't routinely use the IVIG therapy. We just started anakinra. In Rasmussen, we continue up to 2 years IVIG therapy in Rasmussen encephalitis, or also in the autoimmune encephalitis related to antibody related to the immune epilepsy cases.
Okay, thank you.
Thank you.
I see your hand raised.
Hi. May I talk?
Yeah, sure.
Okay. Yeah. I saw in the chat box a suggestion about like intrathecal steroids. I agree they may work. Actually, I think we have a lot to learn about fires, and I think we will increase our knowledge or the pool of knowledge because we just started to recognize this entity. So probably we will, if not controlled studies, at least we can have concurrent controls. So some centers will prefer one, and some others, sometimes due to availability, prefer another medication. So that's one thing. And I think also fires may have a heterogeneity in itself, because as probably most of you are aware, there are some genes that are being defined in the background of these patients, like TNF-alpha or various inflammatory genes. So the genetic background might show us the way to take up for the treatment or which agent to choose. In any case, the agent will probably target the innate immunity or the early stages of inflammation, rather than like something like rituximab, which is a more specific drug. But as I said, we probably need to bring together our experiences and then form a little comparative study, probably. Thanks.
Yeah, thank you. We will quickly move on to the next theme of case presentation. This is Dr. Lokesh from AIIMS Jodhpur. Lokesh.
Hello, good evening, everyone. So, without wasting time, I invite Dr. Kanda Kumar, who is a pediatric neuro fellow with us, and he will be presenting this interesting case where B cell and T cell will interplay and cause epilepsy. Kanda, please start.
Good evening, everyone. Am I audible, sir?
Yes, yes, yes.
Okay. Is my screen visible?
Yeah, please go
Yeah.
ahead.
Myself, Dr. Kanda Kumar. I'm fellow in pediatric neurology from AIIMS Jodhpur, and my moderator is Lokesh Saini, sir. Today I'll be presenting an interesting case, and the topic of my talk is when the brain ignites, targeting the spark. So moving on to my first case, this is a 6-year-old boy who was premorbidly normal with age-appropriate development, presented to us with chief complaints of fever for 7 days, headache for 7 days, multiple episodes of abnormal body movements for 3 days, and altered sensorium for 3 days. His illness started with fever, which was low grade to start with, and was not associated with any chills, rigor, or rashes, intermittent in nature, and there was no any specific foci of infection. Headache, it was insidious in onset, not associated with any aura. It was more during early morning, diffuse dull aching type, and it was progressive in nature, and it was aggravated by cough and sneeze. And seizures on day 3 of illness, it was right focal motor seizures with impaired awareness, and there were multiple episodes, like around 5 to 6 episodes per day, and each episode was lasting for 4 to 5 minutes. Simultaneously, he also developed altered sensorium in form of lethargy, decreased responsiveness that progressed to deep encephalopathy within the next 36 hours. And there was no history of any viral proton preceding the illness, and there was no history of any unknown bite, recent travel to forest areas, recent vaccination, head trauma, and there was no history of joint pain, joint swelling, alopecia, oral ulcers, or high colored urine, and there was no history of contact with TB patients. For these complaints, he was admitted in a local hospital for 3 days, where he received IV antibiotics and anti-seizure medications. But however, he had a deteriorating course, so he was referred to us for the further management. He had an uneventful past history with smooth perinatal transition, with age-appropriate development, and he was partially immunized for age. So at the time of presentation, on general physical examination, he had pallor with stage 1 hypertension. Actually, he presented to us with right focal status epilepticus. His seizures was aborted, airway management was done, and after that, on focused neurological examination, he was found to be deeply encephalopathic with GCS of E1, BT, and M3. His pupils were equal and reactive with grade 1 papilledema, and other brainstem reflexes were intact. Tone was increased in both lower limbs with brisk DTRs, and more than 3/5 power was present, and there was no meningeal signs. So our working diagnosis was acute febrile encephalopathy with focal status epilepticus with features of raised ICP. And the child was critically ill at the time of presentation. So initial possibilities of viral encephalitis or any tropical infection related meningoencephalitis or TBM were considered, and non-infective causes like itis, that is infection triggered encephalopathy syndrome, especially ALERD or FSCUB were considered, and encephalopathic demyelination, especially the cortical encephalitis variant of MOGAD or fulminant ADAM was also thought of, and autoimmune encephalitis was also a possibility. So initially his airway, breathing, and circulation was stabilized, and he was started on anti-raised ICP measures, including osmotherapy, and broad spectrum antibiotic cover was given. He was also started on acyclovir, and anti-seizure medications were going on. He was on full dose levetiracetam, lacosamide, and midas infusion at 5 mics per kg per minute. And CT head was done, which showed a left hemispheric cerebral edema without any leptomeningeal enhancement. So a clinico-radiological possibility of FSUB, that is focal status epilepticus with unilateral brain edema, was made, and the child was started on methylprednisolone pulse therapy within 3 hours of presentation to our hospital. So coming to his laboratory parameters, he had an lymphocytic pleocytosis with elevated inflammatory markers. His ESR was 54, CRP was 110, but his IL-6 was highly elevated. It was 54,600 picograms per ml. And his workup for tropical infections were negative, and his blood culture was sterile. CSF analysis showed only a mild elevation in proteins without any pleocytosis. his CBNAT, CSF or CBNAT was negative. And we have also sent MOG antibodies, CSF, NMDA, and paraneoplastic panel, which was avoided. So we went ahead with MRI. Image A is T2 weighted axial T2 image, and B and C are diffusion weighted imaging. In first image, we can see there is T2 hyperintensity involving the cortical gray matter of left hemisphere, predominantly over the parieto-temporal areas. And in B and C, similar areas are showing diffusion restriction with the reversal in ADC also. And in ASL image, we also found that there was increased perfusion over the left cerebral hemisphere. So coming to the clinical course, the child was very sick at the time of presentation. He required mechanical ventilation for 7 days, considering status epilepticus and deep encephalopathy. And antibiotics were stopped after 5 days, as his cultures were sterile and his CSF viral panel was negative. And methylprednisolone pulse therapy was continued for 5 days. But on day 3 of illness, he developed a flurry of focal seizures again, for which second-line immunotherapy was initiated. He was given IVIG at 2 grams per kg, after which he had some clinical improvement. Seizures frequency has reduced, and we were able to taper MIDAS also. And we have extubated the child on day 7 of illness. So after extubation, his sensorium was better. He had a GCS of E4, V4, M6, and there was no further seizures. But however, we noticed the child was having severe behavioral abnormalities. He was very aggressive. He had irrelevant talks, and there was refusal of feed also. And meanwhile, we got MOG antibodies also, which were strongly positive. So the final diagnosis we made were Flames variant of MOGAD. And considering his persistent behavioral abnormality, we went ahead with the third immunotherapy. Rituximab was given along with the Septran and fluconazole prophylaxis. So we were able to discharge the child at day 18 of illness. So at discharge, the child was conscious, oriented, his behavioral abnormalities were controlled, and his MRS modified ranking score at the time of discharge was 1. So on a 6-month follow-up, he did not develop any cognitive or motor deficits. All his behavioral abnormalities were resolved. But however, he developed right focal epilepsy. But however, it is occasional. He used to have 1 to 2 episodes in every 1 or 2 months, which was controlled on single anti-seizure medications. So coming to the Flames variant, it is a subtype of MOGAD with usually presence in the adolescent or adult age group with 60% male predominance. So it has 4 key clinical features, including seizures, headache, fever, or cortical symptoms, which are related to the site of where flare hyperintensities are seen. Maximum 95% of patients will have 2 out of these 4 features. And coming on imaging wise, it is predominantly a unilateral phenomenon, but however, contralateral hemisphere involvement can be seen in 20% of patients. Key features include hyperintensities of cortical gray matter with gyral swelling in flare, with diffusion restriction and reversal in ADC, with decreased oxygen extraction in SWAN image, and increased perfusion in ASL, with ipsilateral vasodilation in angiography, and sometimes there can be unilateral leptomeningeal enhancement also. And radiological DDs would be FSVB, which may evolve into HHC, or MELAS, or virus, which is causing focal encephalitis like herpes. And there is one more variant of Flames, which is FUEL, which is flare variable unilateral enhancement of leptomeninges, where flare may be normal, only we will be having an unilateral leptomeningeal enhancement. As in this, we can see in this image, only there is leptomeningeal enhancement involving the involved hemisphere. So we all know that MOGAD is predominantly a disorder of adaptive immunity, especially the humoral immune dysregulation. In certain phenotypes, especially in the non-demyelinating variotypes, say cortical encephalitis like phenotype, or in Flames, there can be dysregulation of innate immune system also. As in our case, we can see that IL-6 was very highly elevated. So recent evidence also suggests that early initiation of second-line immunotherapy may be warranted in severe cases, and there sometimes MOD can have an isolated epilepsy-like presentation. So the patient may not have a demyelinating episode throughout his lifetime, and even MRI can be normal, only it can present as an autoimmune epilepsy. So the take-home messages are, usually the Flames variant of MOGAD are generally responsive with the glucocorticoid monotherapy, but however, our index case required triple immunotherapy. Highly elevated markers of innate immunity like IL-1, IL-6 may predict a catastrophic downhill course. and patients with status epilepticus like presentation with cortical encephalitis like phenotype with strong positive MOG antibodies may warrant an early initiation of rescue therapy, especially plasma exchange or tocilizumab. Thank you.
Thanks, Dr. Kanda. MOG never fails to surprise us. Dr. Banu, your thoughts?
Hello.
Yeah, Dr. Banu, we can
Hi.
hear you.
Yes, very interesting and instructive case. I also wanted to emphasize that the MRI in these cases can be normal, so we may not see any hyperintensity or any diffusion changes. It is something to keep in mind. I just wanted to point it out that.
Dr. Chan?
Oh, that's a very nice case, and I think it's nice to see how you haven't allowed yourself to be kind of I guess tethered by all kinds of tests, but you've empirically gone ahead and done what was best for the patient. So cover with antibiotics and started pulsing and added IVIG. I mean, I think we got some questions in the chat, or should we do IL-1? Should we do IL-6? I think ultimately our goal has to be think of the patient first and foremost, right? And empirical therapy is still faster than some of our test results can come back. And it is safer for the patient to do that rather than wait for definitive evidence of some kind of immune dysfunction before we dare to use immunotherapy. So I applaud you.
Dr. Maya, anything?
Yeah, I think, it's just, matter of terminology. This was earlier called the hemiconvulsion hemiplegia epilepsy syndrome. And of course, with identification of antibodies, you can have hemispheric involvement with MOG antibody. You can have diffuse cortical encephalitis with MOG. So I think again, and this only tells us that, with the with the expansion of these antibody panels, we are only going to see more and more of this. And obviously, you have done the right thing. And of course, it's important again. Is it the earlier what we call the Rasmussen's encephalitis? Initially, they start off with like a acute presentation, and subsequently they go on to develop chronic epilepsy. Is this one of those? So definitely this child definitely requires follow-up to see if there is progressive atrophy of the brain as well. So I think definitely this requires follow-up as well.
Yep. Thank you. Lovely case. We move on to the third one. Dr. Raju? Dr. Raju and the team? Sir? Dr. What? Perfect. Dr. Namrata, all yours. You can please take on. We can't hear you, Dr. Namrata. We can see the slides, but we can't hear you. Dr. Namrata, we can't hear you. You will have to unmute yourself.
Sir, am I audible?
Yeah, you
Good
are
evening,
now.
all. I myself, Namrata, I'll be presenting an interesting case under the guidance of Dr. Vaikunth Raju. Here's a 9-year-old male child brought with complaints of paroxysmal events since 27th of May 2024 and complaints of decreased hearing followed by vision disturbances as well from 3rd of June. And following this, the child also developed unsteady gait and altered sensorium. So this child on 27th May developed paroxysmal event in the form of left clonic seizures at 4 a.m. while the child was in deep sleep, which lasted for 20 minutes, followed by post-ictal drowsiness. The child was given levetiracetam on OPD basis in a private setup and was discharged. The child was apparently all right till 2nd to 3rd of June when he started becoming irritable and complained of sudden onset difficulty hearing, and when the mother was trying to converse with him. And he also complained of hearing everything twice. He was able to speak well till the next day or two when child started to have decreased word output. He started communicating mostly through sign language by that time and had only 1 to 2 words, simple words that he was using to communicate his needs. By June 7th or 8th, mother noticed child to have visual disturbances as well in the form of difficulty gauging distance, height, or depth. Also, child had visual hallucinations as he complained of seeing a lion on that day. Mother noticed child to have tremulousness of hands, legs, and neck during this time, and this was present both at rest and increased while reaching objects. On June 13th, the child was admitted in a private setup where the child transiently had complaints of complete vision loss for half a day. And during this time, child was given only IV fluids and recovered by just with by itself. And for these complaints, the child was referred to Indira Gandhi Institute of Child Health. And during transit, the child developed second episode of paroxysmal event. This time it was right focal clonic status epilepticus lasting for 20 minutes, followed by post-ictal drowsiness. And when we received the child on 17th of June, the child had swaying, was received on wheelchair as the child had excessive swaying with recurrent falls and tremors of the hands, as well as of the neck. Some hearing and visual impairment that the mother complained of, and simple 1 to 2 words the child used to use occasionally to communicate his needs. The child was excessively irritable at that time. And also there were complaints of difficulty falling asleep. However, there was no complaints of any fever, headache, or projectile vomiting, no weakness of extremities, no cranial nerve involvement other than this vision and hearing impairment that the mother complains of, and no loss of bowel or bladder control. There was significant past history in terms of the child having history suggestive of varicella infection at around 7.5 years of age. And at 8 years of age, after a tooth fell out, the child had excessive bleeding and the child was evaluated for the same. The child had decreased hemoglobin at this time and also was noticed to have multiple bruises at IV sites and even where BP cuff was tied. The child was diagnosed with severe aplastic anemia, and the child was in severe anemia and failure even after multiple PRBC transfusions, and therefore they had gone ahead with the bone marrow transplantation before the exact etiology of aplastic anemia could be figured out. And this was done on 26th of August 2023, and around 275 days later, after the bone marrow transplant, the child developed the above complaints that we already mentioned. This child was a third issue for non-consanguineously married couple with normal birth history. And development-wise, the child was supposed to be in 4th standard by this time, but discontinued school since 1 year because of the plastic anemia the child had. But even prior to that, the child had poor scholastic performance and poor arithmetic skills. The mother says that the language and cognitive milestones were all delayed compared to siblings. And also, the child started walking only after 1.5 years. However, the child was able to read and write before the illness. When we received the child was already on certain prophylactic medications, including acyclovir, penicillin, and cotrimoxazole, along with cyclosporin. Child was on anti-seizure medication. So here we had a 9-year-old male child born to born to non-consanguineously married couple with normal perinatal history. Baseline mild GDD, mild intellectual disability, and after 275 days of bone marrow transplant, had come with complaints of 2 episodes of paroxysmal event in sleep and subacute onset ataxia and encephalopathy, vision and hearing impairment that the mother and the child complains of with decreased word output and some visual hallucinations as well. So we had kept the following differentials in mind with developmental epileptic encephalopathy with spike wave activation in sleep and post bone marrow transplant CNS autoimmune encephalitis and opportunistic infections were higher in the ladder as well, keeping the immunosuppressed state. And other differentials were post bone marrow transplant CNS malignancy or chemo brain or Robin encephalitis. On examination, the vitals were stable. And on anthropometric examination, the child was underweight. Otherwise, anthropometric was normal. The head-to-toe examination, the child had hirsutism and hyper and hypopigmentation of skin, sparing the lips. There was a butterfly-shaped diffuse thyroid swelling, which moved on deglutition. Also, the child had umbilical hernia and some palmar erythema, which was noted. In higher mental functions, the child was noted to was unable to follow verbal commands, was occasionally speaking few simple words to indicate needs, and there was no repetition, no naming, or communication was mostly through actions. The child was not able to comprehend any verbal commands. This is the video showing where we were trying to ask the child to look up, but the child was not understanding or following any commands, and only on the mother showing repeatedly in action to look up, the child started to look up after multiple trials. Cranial nerve examination, cranial nerves were mostly normal except for the 8th cranial nerve, where the child was not turning towards sound and occasionally responded to only loud sounds. There was occasional response, and the child communicated mostly in sign language. On motor system examination, the tone was mildly decreased in all 4 limbs with power of more than 3/5, and reflexes were brisk with plantar extensors. And there was postural and intentional tremors also noted. There was cerebellar ataxia and head titubation noted with dysmetria, which was also present, and absent nystagmus. The meningeal signs were absent, and craniospinal axis was normal, and other system examination was normal as well. This is the video of this child after IVIG that we gave. The child had cerebellar ataxia, which had already drastically decreased. We did not have a prior video. And some neck titubation as well that the child had. This child now with mild intellectual disability, with quadriparesis and cerebellar ataxia, with focal clonic seizures, with vision and hearing disturbances, with neuropsychiatric symptoms, with thyromegaly. We thought of Hashimoto's encephalopathy or STREET, that is steroid responsive encephalopathy with autoimmune thyroiditis, or some malignancies and opportunistic infections also were kept in mind with the status of post-bone marrow transplant in view of acquired aplastic anemia. We went ahead and investigated the child to find that the aplastic anemia was completely resolved and the CSF was normal. Encephalitis panel which was sent was negative from a reliable lab, but the PG had missed and sent, 2 PGs had sent the CSF sample to 2 different labs by mistake. And it tricked us so much that there was one report which said that HSV PCR was positive in the patient and another report which said that HSV PCR was negative. And this confused us, but with the background of CSF being normal, we still went ahead and managed herpes, thinking that herpes encephalitis is still a possibility. We went ahead and managed HSV as well. So when we evaluated, TSH was elevated and anti-TPO and anti-thyroglobulins were also significantly elevated. So this was an MRI image of this child showing T2 and flare hyperintensities noted in the right high temporoparietal regions without contrast enhancement or diffusion restriction, which was likely post-ictal changes. We did a 1-hour EEG as well, which just showed the multifocal epileptiform discharges with asymmetric background. Another investigation which helped us further was the audiology report, where the child again was seen to have no response to speech sounds, but to non-speech sounds, some awareness was present. And the late latency response was absent bilaterally, which suggests cortical deafness. We did the bone age was looked for to see the age of onset of hypothyroidism, and the bone age was corresponding to the chronological age. USG thyroid showed diffuse thyroid disease, and HRCT thorax showed mild cardiomegaly, which could be explained by the hypothyroidism the child had. In view of the child being on acyclovir prophylaxis already, and we started on IV foscarnet for the child. And since HSV PCR was positive from one lab, we did not want to risk, and we started the child on IVIG instead of steroids. And we repeated the HSV PCR after a few doses of foscarnet, and the PCR came negative. And then we started the child on steroids as well, along with the anti-seizure medications which the child was on. At discharge, the child. So at admission, the child had come in wheelchair, but then by the time the child was discharged, the child was able to walk and the swaying had completely reduced. So was the tremulousness. And there was improvement in the word output. The handwriting was still untidy but legible. And the MRS score had increased from 3 to 2. And after 1 month of follow-up, the child completely had no ataxia, and there was significant improvement with minimal impairment. Differential diagnosis, we strongly suspected Hashimoto's encephalopathy in this child, with all the features mostly pointing for the diagnosis, with seizures, ataxia, and neuropsychiatric symptoms, and the thyromegaly, and followed by investigation supporting the same. And there was very good improvement with immunotherapy. An MRI brain showed only non-specific changes. HSV encephalitis was thought of keeping focal seizures in mind when the child being on acyclovir prophylaxis. Altered mild presentation was also possible. So we still kept that in mind and treated for it initially. However, as PCR turned out to be negative, we went ahead with treating for Hashimoto's. Developmental epileptic encephalopathy with spike wave activation in sleep and bone marrow. CNS malignancy, CNS opportunistic infections, and side effects of pre and post bone marrow or transplant drug therapy were also considered and reasonably ruled out. Sorry. The questions that we had in mind during the evaluation of the whole course was that what is the cause for acquired aplastic anemia in this child was not found, and can a child with varicella develop aplastic anemia 6 months after the infection was another question. Hypothyroidism could have developed prior to bone marrow transplant, and as part of the part of any autoimmune process was what we suspected as aplastic anemia could have been because of an autoimmune process, and as a contiguous disease, even autoimmune hypothyroidism could have been there. And if it was prior to the bone marrow transplant that the child had Hashimoto's thyroiditis, didn't the bone marrow transplant immunosuppressive therapy was not sufficient for treating this autoimmune hypothyroidism was a doubt that we had. Does it point at probable autoimmune hypothyroidism post bone marrow transplant and not autoimmune mechanism beginning from even prior to bone marrow transplant was also in mind. Could post bone marrow transplant immunosuppressive drugs cause the manifestation as side effects? Or when acyclovir was given as prophylaxis for nearly a year, why then did the child develop HSV PCR positivity in CSF? Was it acyclovir resistant HSV that the child had? Child also had umbilical hernia. Did child have hypothyroidism since infancy? There was some baseline intellectual disability as well. The mother was very hyperactive, very lean, and we thought of, because she was the donor for bone marrow transplant, was it possible that the autoimmune disorder was transmitted by her during bone marrow transplant was another concern we had. So keeping all these things in mind, we went ahead with the literature review.
Bida, can you just come to the end? We've already crossed the thing, now it's already crossed 9 minutes. Yeah. It's 10 minutes actually. Please come to your conclusion.
Okay. So this is the criteria for Hashimoto's encephalopathy, which the child met. And post-bone marrow transplant, neurological complications are known. So we have to rule out infections and post that drug-related toxicity, cerebrovascular events, and immune-mediated disorders should be kept in mind. There are very few case reports of post-bone marrow transplant autoimmune encephalitis. One of them is this, where also the child had Hashimoto's encephalopathy, but had leucin-rich glioma inactivated 1 protein antibodies also present in this child. So autoimmune processes are known post-bone marrow transplant. We went ahead and evaluated all the drugs that the child had received pre and post bone marrow transplant and looked into the side effects if such delayed presentation side effects could be seen. But such acute onset of symptoms could not explain could not be explained by the side effects of these drugs. So take-home messages. Once infectious causes are excluded, an autoimmune or inflammatory processes may be suspected in an immunocompromised child with encephalopathy. Autoimmune mechanisms could be etiology of ongoing disease in bone marrow transplantation, ongoing disease in the bone marrow needing bone marrow transplant, or complications of bone marrow transplant, or could be transmitted by donor through bone marrow transplant. Autoimmune thyroiditis is an association rather than causation. cognitive impairment, behavioral changes, tremors, myoclonus, transient aphasia, sleep abnormalities are a few of the features of Hashimoto's encephalopathy. Hashimoto's encephalopathy shows good response to steroids and sometimes might need IVIG and other second-line immunotherapy. Thank you.
Thank you. I think we'll quickly go to the fourth case presentation and then take on the thought process of everyone together. Dr. Mahesh, sir, can we have your team present the fourth case?
While the slide has been shared, Raju, you want to add something in 30 seconds?
Yes, madam. It is a very complex case. So whenever child presents with seizures, especially with associated other symptoms, you should always consider immune-mediated mechanism. And unusual features are in this child already on immunotherapy following post-transfer. Despite that, child has this immune-mediated epilepsy, so it should be high index of suspicion. This treatable condition should be considered. They can present, autoimmune is known to present various symptoms, but they can present like this predominantly speech and language problem along with infrequent seizures also. So you should consider this one of the possibility. And the examination like thyromegaly can be there, sometimes gives clue for underlying Hashimoto's encephalopathy.
Thank you. Sorry, Vishal, I'm pitching in between because, they already, we are 30 minutes beyond and I know it's not right for the next, but what we'll do is we'll have the next case briefly, Mahesh, and then we will request all the experts to give opinion, their comments for the last two cases, as well as a take-home message. And Derek has to, Derek and all the other experts as well have to give a take-home message. That's customary. So we will just wind up fast. Sorry, Mahesh, Gayatri will have to rush.
Yes,
All
ma'am.
cases have been wonderful actually, and the talk was fascinating, but the cases are also wonderful, but please be fast.
I hope my screen is visible and I'm audible.
Yeah, all good.
Yes, sir. Good evening, everyone. I'm Dr. Gayatri Pawar, DM Pediatric Neurology Resident from JNMC Belagavi. I'm guided by Dr. Mahesh Kamble, sir. Our case is CNS HLH presenting with seizures and abnormal movements in a boy with Griscelli syndrome type 2. So we had this 2.5-year-old male child with gray hair since birth. He was brought to us with complaints of swaying while walking for 15 days that led to repeated falls, abnormal eye movements for 8 days, and abnormal intermittent shaking of head and jerking of limbs for 6 days, with history of excessive irritability and disturbed sleep, history of reduced speech, history of abnormal tonic posturing of 3 episodes during the hospital stay. He was born to non-consanguineously married couple with birth history and development being normal. This is a video showing unsteadiness and staggering gait, which was noticed by parents as the initial symptom at home. We noticed abnormal fast jerking movements of left upper limb, which is seen in this video. Similar kind of generalized movements were noticed in other parts of the body, which were intermittent, lasting for about 5 to 10 minutes with multiple episodes in a day. He had rapid, repetitive, conjugate, involuntary, chaotic, multidirectional eye movements that were noticed. Child also had generalized tonic seizures, 3 episodes during the hospital stay, each lasting for about 3 to 5 minutes. On examination, child was irritable. He had silvery gray hair. Tone was reduced in all 4 limbs. His bilateral plantars were extensor. Generalized myoclonus and at times focal myoclonus was noticed. Titubation and truncal ataxia were noticed. There was no organomegaly or lymphadenopathy noted. Hair was examined under light microscopy, in which the top hair here shows patchy irregular clumping of pigment in the medulla. His Michelin-Pike OMS rating scale amounted to 16. On investigation, he had mild anemia with HB of 9.2. CSF showed pleocytosis with 9 cells with normal protein and glucose. EEG did not reveal any epileptiform discharges. His HLH workup showed no evidence of hemophagocytosis on bone marrow, and serum ferritin and triglycerides were normal. MRI showed flare hyperintensities in bilateral periventricular white matter, corona radiata and centrum semioval, and also bilateral cerebellar white matter. So our differentials were likely Griscelli syndrome because he had silvery gray hair syndrome. irregular clumping of hair on light microscopy, and neurological manifestations. Other DDs were ADEM and autoimmune encephalitis. Why we considered CNS HLH was HLH with neurological manifestations are common in this Griscelli type 2. CNS HLH can occur isolated without systemic features. White matter lesions are more common in isolated CNS HLH, and 61% can have cerebellar involvement. So we went ahead with genetics that showed mutation in RAB27A, which is the gene for Griscelli syndrome type 2, which was autosomal recessive homozygous, though it was VUS. So our final diagnosis was Griscelli syndrome type 2 with acute onset encephalopathy with seizures and features of OMAS with isolated CNS HLH. So we started on chemotherapy based on HLH 2004 protocol consisting of etoposide, dexamethasone, cyclosporin, and intrathecal methotrexate with hydrocortisone. Sodium valproate and parampanel were given for seizures and myoclonus, and antibiotic coverage was given for infection, and child was further advised for stem cell transplantation. This is at 3-month follow-up on maintenance chemotherapy. Child had improved neurological symptoms, but unfortunately he succumbed around 3.5 years due to sepsis. So HLH in Griscelli syndrome type 2, it is an autosomal recessive disorder which is characterized by hypomelanosis and silvery gray hair with immunodeficiency and late onset HLH. HLH represents a type of cytokine storm syndrome characterized by uncontrolled inflammation and immune dysregulation. CNS HLH can occur in the absence of systemic features. So RAB27A, it plays a key role in exocytosis of cytotoxic granules from the cytotoxic T lymphocytes and NK cells. So whenever there is defective cytotoxic granules exocytosis, the infected antigen presenting cells are not removed. So uncontrolled proliferation and activation of immune system with release of excessive cytokine occurs with activated macrophages infiltrating the other organs. The neuropathology involves stage 1 being leptomeningeal inflammation, stage 2 of extension to perivascular inflammation, stage 3 where there is lymphohistiocytic tissue infiltration, tissue necrosis, and blood vessel destruction. So seizures in Griscelli type 2 is due to accelerated phase causing HLH and CNS infections due to immunodeficiency. Seizures, meningism, irritability, and altered level of consciousness are common clinical features of HLH. Seizures are most common neurological symptom occurring in about 33 to 83% of children. And CNS HLH manifesting with OMA is not described in literature. Presence of neurological signs and symptoms, neuroimaging abnormalities, and CSF abnormalities give clue to the diagnosis. Neuroimaging has mainly these cerebellar abnormalities, diffuse and multifocal white matter. Treatment is basically the HLH 2004 protocol, which is similar to the systemic HLH. Continuation chemotherapy during the remission act as a bridge before stem cell transplantation. Thank you.
Mahesh, very brief comment.
Yes, this is a case of Griscelli syndrome, which came to us with abnormal eye movement and seizures, ma'am. Basically, child had OMA secondary to HLH, and HLH had seizures also. We plan to do stem cell transplantation, but our patient could not arrange for the BMT and maybe succumbed. Treatment of HLH did result in improvement of seizures, but because we could not do stem cell therapy, we lost the baby.
Thanks, Mahesh. Vishal, actually, those people could be writing in Q&A. Derek is very kindly being answering them, but I think there are lots of questions in the chat. Can you just pick up those points and ask, those 2, 3 which are here?
Go through a couple of questions. Dr. Chan, one of the questions which interests me also is there any definitive duration? Now we are talking about Rasmussen's. Is there any definitive duration for stopping the maintenance immunotherapy? Let's say the disease is in remission. So how do you decide that, okay, now I can give it a break?
I think it's very difficult because, okay, my experience with immunotherapy and in Rasmussen's has actually been not that successful. I tend to find it slows the course rather than cures them. And the ones that I've experienced with eventually all end up with a hemisterectomy. I think it's a little bit, I guess you can think of it a little bit like, patients who cancer, like severe stage cancer and are in remission. You have to be very, very tentative about whether to wean off treatment, because the treatment is what got them under control. And we probably don't have enough of a handle or good biomarkers to be sure that we have completely extinguished the underlying problem.
Perfect. Another one is, what is the protocol of anakinra that you use? The dose, the frequency, and the stuff.
Yeah, so anakinra is a daily injection. Off the top of my head, I can't remember. I don't want to misquote me, but I think it's something like 4 to 6 milligrams per kilo, and I think the maximum is like 100 milligrams. But I'd go and double check that. But it's a daily injection. It isn't cheap. There was other questions about using tocilizumab. The reason I don't use anakinra, I don't use tocilizumab, is I have more experience with anakinra, and there is some talk about tocilizumab not having as much penetration into the CNS. Also, anakinra hits the immune cascade further up, so it hits at interleukin-1, whereas tocilizumab starts at interleukin-6. And so, if you only aim at interleukin-6, the worry is that you may actually miss some of the pathways and the inflammation could continue. So that's my kind of approach. Like we said with the first case, it's actually difficult to decide how long to give it for. The FIRES cases I've had, I use the EEG as the biomarker. So one of the patients, we gave 2 weeks, we repeated the EEG, and it was still very, very epileptic. So we gave another week, and actually we could see a significant change in the EEG. So by the 3rd week, we could start to taper off, not the anakinra, but the anti-seizure medicines. And again, there's very little literature about how long to keep it on. We kept her on the anakinra for several months. But I think the earlier we start, then sometimes we can get away with a shorter course of, down to several months. Hope that's helpful.
Vishal, Dr. Derek it's going to be 12:30 a.m. So one or two questions maximum before. I think
we most of the questions have been answered by Dr. Derek in the chat box itself.
Okay, thanks. Then
over to you, ma'am.
really, I'm just requesting Dr. Derek for any comments in the last 2 cases and the final take-home messages. And then we're coming to Dr. Banu, Dr. Maya, and Hassan.
Yeah, thanks so much. I just want to share, I'll just share personal experience. Hashimoto's encephalopathy, I've been caught out with one of them. It looked like Hashimoto's, and then it turned out to be a patient with MELAS when we finally got the scan. I think the TPO antibodies are tricky. They can be up for all kinds of reasons. So for that reason, the Hashimoto's is a little bit tricky to be sure what we're dealing with there. The last case was interesting because I don't know if, this is, I'm not going to ask for an answer, but graft versus host disease just crossed my mind because of the transplant and stuff like that. And of course, some congenital metabolic thing, was there something underlying there because of the aplastic anemia? But yes, of course, autoimmune certainly is up there in the differential diagnosis. I guess take-home message I'd say is that it's important to think about all these autoimmune etiologies. It shouldn't replace our conventional wisdom and training and knowledge. So we must always still keep in mind common things are common, and all the things that we've been trained in, conventional epilepsy, refractory status epilepticus, the cortical malformations, all of this, we still have to do that very, very well, right? But we layer this thoughts about autoimmune etiologies, and we add that to our differential diagnosis, and we need to tune up our familiarity with the clinical phenotypes so that we can empirically start to treat at the appropriate time, not depend on necessarily lab results to tell us what to do, but really be driven by that clinical phenotype, and at the same time start to build that infrastructure to actually help us to make more sense of what's going on with all these autoimmune brain diseases. That was a very long take-home message, but thanks so much. And I want to say thank you so much to Shefali for inviting me to speak.
Thank you. Thank you. It's amazing, Derek. I think, it's 12:30 midnight, 30 minutes past. Dr. Balu, your take-home message and any comments on the last two cases?
The case with aplastic anemia, we were not given the upper limits of the thyroid antibodies, but I guess they are more than 10 times high. So it is rather, it's not non-specific. I believe the child had thyroid encephalopathy, especially the presence of myoclonia among the multiple types of seizures. So I would wonder if with the aplastic anemia and with the autoimmune thyroiditis, would the child have an autoimmune predisposition, which means a selective immunodeficiency in the background? So I would wonder what the whole exome sequencing would show. For the second case, HLH, yes, one thing to remember is the silent infections of the central nervous system because of the opsoclonus. We have a case series published by Yildirim as the first author, where one of the children was a post-transplant leukemia case who had opsoclonus, myoclonus, and ataxia, not due to leukemia, probably due to the virus that was shown in the CSF. So I would wonder if there was an EBV or herpes type of virus, because viral encephalitis, silent in this case, where the immune response is already mitigated, would have caused the encephalopathy. Thank you.
And your overall take-home message for the session? Take-home message for the session. Immunity and epilepsy. Any take-home messages for us?
I would quote Dr. Chan's take-home message. Consider frequent etiologies, infections first, which I believe all our participants agree with. Rule out encephalitis, and then think of the zebra, which is fires in this case.
Thank you. Thank you. It was amazing to have you, Dr. Maya. And Dr. Biju, I would request you also to say something from London. We'll have that part of high income things. Yeah. Dr. Maya.
Yeah, thank you for everybody for those nice cases. The post-BMT syndrome was quite complex, and there were too many factors involved. So one really can't say. And I guess follow-up and response to immunotherapy is what is important. Like you already mentioned, the elevated thyroid antibodies is more an association than a causation. That's all my take on that. With regard to the Griscelli syndrome, my only thing was how was the HLH? Was it did we go by the diagnostic criteria, or did we have any tissue diagnosis? Because Griscelli itself can have neurological manifestations without any other reasons. So that was the comment on the Griscelli and neurological syndrome. Regarding a take-home message, again, like I said, the most important thing is response to immunotherapy to make a diagnosis of autoimmune epilepsy, and follow-up and revision of diagnosis, revision of treatment is, I think, what is most important. Thank you.
Thank you, Professor Hassan. And Dr. Biju, like to add something?
Thank you, Dr. Shefali. I think all the issues related to the immune epilepsy, I'll discuss them, and we get a lot of fantastic take-home messages. My take-home messages: what is the best imaging or biomarkers for immune-related epilepsy? Epilepsy is a network disease. in the future, I think we have to be understand what is the exact mechanism of the immune-related epilepsies, and then which is the best neuroradiological imaging for the immune-related epilepsies, and diffusion tensor imaging, something like that. There are some macromolecular changes. It's different from the structural epilepsy and some genetic epilepsy. There is also genetic ways of the immune-related epilepsies. I think my take-home message is we have to be need more basic science studies on the immune-related epilepsies for the epileptic immune networks.
Thank you. Dr. Biju?
Thank you.
Thanks, Dr. Hassan. Dr. Biju, you want to add something? Dr. Vishal?
I think it's been summed up almost completely, ma'am. And we can give him a break now. Dr. Chan has been hanging on for quite a long time.
Yeah. Thank you so much. Thank you very much, Dr. Derek, for staying so late. And it was an amazing session with amazing talk from you and wonderful cases and wonderful discussion from the experts. Thank you so much, and look forward to you for the AOCCN. And I think we just end off the video again. And the registration is open. You have to scan the QR code, and abstract submission is also on. You can scan the QR code, and then you can, we'll be sending out the symposium proposal in 1 or 2 days. Thank you very much. We'll see you after 2 weeks.
Thanks so much.
And thanks. Asmita, you can. Good night. Thank you.